Welcome to mpnuniversity.tv Clinical Insights. This discussion is about allogeneic stem cell transplantation in patients with myelofibrosis and is moderated by Dr. Srdan Verstovsek and co-moderated by Dr. Ramon V. Our panel discussants are Dr. Bart Scott, Dr. Olatoyosi Odenike, and Dr. David Snyder.
We are making a progress in a therapy of myelofibrosis. New therapeutic agents are being investigated, and one of them, a JAK inhibitor, was approved several years ago as the first therapy for myelofibrosis. But we don't have a therapy that would eliminate disease or cure the patients. The bone marrow transplant is still the only one. So we convene here today to discuss the role of the allogeneic stem cell transplant in therapy of patients with myelofibrosis. When is the best time? What are the best patients? How do we approach that? Now that we have a medication on the market that we can prescribe, does this affect the decision making? What's your take, Bart, on timing on the bone marrow transplant in patients with myelofibrosis? Is it simply sooner the better, or shall we discuss it and see what is the optimal approach?
Well, it's definitely not sooner the better. Okay. I think there are some patients who should honestly never be transplanted for their diagnosis of myelofibrosis. The thing is, I would like to say that 100% of people survive after a stem cell transplant for myelofibrosis, but the fact is that many people don't. And the treatment-related mortality has been reported as high as between 30 to 40% of patients who die in the first year due to toxicity from the conditioning regimen or from other complications of the transplant. So I think it's very important to select the right patient. And I think everybody agrees on that. But where you might have disagreement is how you go about choosing the right patient and what one would look at to select the right patient. For me, I think that trying to get some idea of what their survival would be without transplant is an important aspect of that decision-making process. So when I see a patient for myelofibrosis, one of the things I would do is I would calculate their prognostic score in the Dynamic International Prognostic Scoring System. And we performed a retrospective analysis and basically showed that the DIPS was predictive of survival even in the transplant population. And I know that there's going to be some abstracts coming up at this most recent ASH meeting that are basically an attempt to answer this question of what is the optimal time to transplant a patient based on prognosis. And I think it's going to be very interesting data for us all to see. Right now, currently what we do at our center is if patients are intermediate to or high risk by the DIPS score and they are a candidate for stem cell transplant, then we would try to do that sooner rather than later. If they're low or intermediate 1 risk, our preference is to offer them non-transplant therapies, and that's because their natural survival would be longer just on the basis of their risk of myelofibrosis. There's other things you consider, like do they have refractory thrombocytopenia, have they had recurrent infections, are they intolerant to other medications, things like that. But I think that the prognostic scoring system is a very important aspect of making that decision.
And you primarily base it off of the DIPS rather than the IPSS or DIPS plus?
We primarily use the DIPS. The problem with the IPSS, of course, is that technically that's only applicable to at time of diagnosis. So I'd like to modify it over time. I have used the DIPS plus as well. You know, as you know, the difference is that the DIPS plus includes cytogenetics, it includes red cell transfusion dependence, and it includes thrombocytopenia. So I think that that is also something that's important to look at, the DIPS plus.
I've had some discussions with some of our transplanters, and I'm not sure what your take on this is, but there have been some patients, of course, who appear to be good. They have intermediate 1 risk disease. But what if they carry a high-risk cytogenetic abnormality? Would you transplant these patients?
Or even mutational analysis that is bad?
Yep. I think that, yes, the answer to that question is yes, as long as they're a good transplant candidate, and as long as the discussion is had with them. I mean, you know, I'm sitting here saying yes, but it's a discussion. You know, you need to discuss to the patient the pros and cons of the transplant, the potential toxicities. You know, it's kind of like up front you're accepting a potential risk for the payout later on to hopefully have a more normal life expectancy. As you said, right now the only curative option for myelofibrosis is a stem cell transplant.
It's a balance of risk and benefit. Like with any medical decision that you have to make, what are the risks and benefits of one approach versus another? So we know for transplant that's the ultimate benefit is cure, but the risks are there as well. So I agree that you don't want to go too soon and compromise good quality of life that someone has. So we use the DIPS score, the DIPS plus as well, so that when a patient reaches, say, intermediate 2, and we know their survival is going to be compromised, that's a time to consider the option. But I have some patients who meet intermediate 2 criteria, and yet they're feeling quite well, they're functioning quite well, and it's hard to argue that they should compromise that good quality at that particular time. But I follow closely. Cytogenetic changes, I think, are an important harbinger of what might be coming. And clearly, you don't want to go too late.
Right.
You don't want to wait till the patient has progressed to acute leukemia.
Yeah.
Right.
Now, in reality, the number of patients that actually undergo the procedure, the transplant, is done in less than 10% of the patients, perhaps more, but it's low.
It depends what center you're at.
Right, exactly.
Now,
Agree with that.
that's important because is the number of, in general, number of the patients that undergo transplant because there is such a discrepancy between the best patients that you would transplant and the typical patient you actually see in your clinic that is sent to you for a transplant,
Right.
and you can't do it? What's
Right.
the problem?
Well, I think that each of us work at different centers with different areas of expertise. I mean, I can tell you that I probably see younger patients with myelofibrosis on average than other people, and I tend to see people who are interested in transplant as an option just because of our referral bias. So yes, I think that what you've said does play a role into the practice of stem cell transplant, the referral bias that people have.
Yes, and I think it's partly education, both of our patients and our colleagues, in terms of who could be considered for a candidate. I mean, it's a moving target as far as what's an upper age, someone who could be considered for transplant, and since most of our patients with myelofibrosis are in the 50s, 60s, 70s, many of our colleagues might not have considered them to be a potential candidate for transplant, but that bar keeps rising. So instead of 50, 55 as an upper age limit, now it's 70, 75 potentially for a candidate.
Now, the a reason for a transplant obviously is to save the patient, and we all agree that intermediate and high-risk patients are good candidates if they're in good condition otherwise. The availability of the JAK2 inhibitor as a therapeutic option, is this making a difference in your view in positive or a negative way in terms of eligibility, providing some toxicity that you don't like to see before, or not having a patient favorably looking at the transplant because they feel better. They don't want to do it anymore.
I think it goes both ways, right? So the positives are that there is a modality of therapy, that is the use of the JAK inhibitors, that can help a patient feel better, improve their performance status, potentially shrink their spleen some before going to undergo a potentially curative strategy like an allogeneic stem cell transplant. So I would say that's a potential upside for the availability, the current era that we are in, putting that in the context of transplant. The potential downside, of course, is that a patient who otherwise, would be a good candidate for a transplant, who, say, maybe has, high-risk disease, is younger, maybe even has a matched, sibling donor, goes on a JAK inhibitor, they are feeling great, and they want to delay that. So I think that's where having, a doctor who is seasoned in the disease and in these modalities, and having that person be able to educate the patient about what the core benefits of JAK inhibitor therapy are and what the potential limitations are, and putting that in a format that the patient can understand so they can make an informed decision.
I don't see it as a substitute for transplant. I agree that it might help pave the way to make the transplant even more effective and safer, shrinking the spleen, reducing some of the systemic symptoms before. But for my patients who are young enough and I am considering as good candidates, I may use a JAK inhibitor to sort of, as I said, pave the way, control signs and symptoms, but not as a substitute.
I agree.
would
I think the
agree
JAK
very
inhibitor
much.
is complementary therapy,
Yep.
but not a substitute for
Right.
stem cell transplant. And so in those young patients who do have high-risk disease or intermediate to risk disease, the use of the ruxolitinib can be very beneficial in the pre-transplant setting, dealing with the cachexia, decreasing their spleen size, making them a better candidate for stem cell transplant.
Right.
Well, that's very important because only 10% go for a transplant. Why don't we make 60% go for a transplant and make those that are not eligible because of a big spleen and poor performance status become eligible? So the question is, should we treat everybody with JAK2 inhibitors before the transplant?
Well,
If they have a symptomatic
Right,
disease
exactly.
and
I
a
was
big
just gonna say.
and a big
I think that's a
spleen.
big if.
Yeah.
If.
Right. If. Right.
Yeah. So I would say that if they do have a big spleen and they are symptomatic, they do have a lot of cachexia, that it would, in my opinion, be preferable to try to improve those before performing an allo transplant, if possible.
And you would then treat them for a certain period of months, all until the transplant itself?
So I can just speak from my own practice, I would treat them until they've had improvement in their symptoms and the donor is available. And then what we typically do is we start to taper before we initiate the conditioning of the transplant. And we discontinue the JAK inhibitor around the time of the start of conditioning, usually about 3 days before, sometimes a week before. And we definitely do not continue the JAK inhibitor during stem cell infusion because of the concerns regarding engraftment.
And then do you have a specific tapering process? Do you actually, add steroids, during the tapering process, or?
No, we have not been adding steroids. We just taper the JAK inhibitor. I think it's important not to taper it too soon.
Yes.
Right.
And you don't want to be
Exactly.
tapering it, while they're
Right.
getting their stem cells.
But I
Right.
think it's still unclear
Yeah.
what's the best
strategy.
strategy
Sure.
for tapering it, for
Yeah.
perhaps continuing it, restarting it.
Yeah.
We know that the JAK inhibitors can reduce spleen size, which might help with engraftment. But beyond that, it may have further benefits in the early post-transplant setting in terms of reducing cytokine release, cytokine storms, perhaps preventing graft versus host disease. And we know there's studies using it as treatment of graft versus host disease. So right now, I think there's a lot of unknowns about
Right.
what's the best strategy for using it. But again, it's an adjunct to transplant, not instead of.
Yeah.
For someone
think-
who has a massively enlarged spleen, prior to going into transplant, is your expectation when you give the JAK inhibitor to also reduce the size of the spleen? Because there's always this prevailing question about, do you improve engraftment by having a much smaller spleen before you give the cells, or is that not really an expectation prior to getting into transplant?
So I think that reducing spleen size does improve engraftment. We have looked at our own data sets and we've shown that patients who have had a splenectomy prior to transplant had ANC engraftment about 2 to 3 days before those, on average, patients who did not have a splenectomy. And that's obviously in the pre-JAK era. I think there are other benefits besides spleen size. I think there are other benefits besides engraftment per spleen size reduction. I think that there is also the potential that it decreases the toxicity of the conditioning itself. Because I think when you have a very large spleen, there's problems with a hepatosplanchnic blood flow. And I think that there are higher risks of veno-occlusive disease, for instance, in
Yes.
patients with massive spleens. So it's not just the earlier engraftment, but I think there's also just actually reduced toxicity from the chemotherapy-based conditioning regimens in patients who have spleen size reduction. either through chemicals like JAK inhibitors or through surgical procedures like a splenectomy.
Have you, do you have a specific cutoff point about, let's say if your spleen size is like 20 centimeters below the left subcostal margin, do you go by volume, do you go by size,
We don't, I'm sorry if I can.
No, go ahead.
We don't exclude a patient based on the size of the spleen. I mean, it would be preferred to have it smaller, and if we can accomplish that with a drug therapy. We don't routinely recommend splenectomy because it certainly has significant risks associated with it, morbidity and mortality, perhaps delaying or even precluding a transplant ultimately. In the short term, not having a spleen at all or having a smaller spleen does show improvements in terms of engraftment, length of stay in the hospital, et cetera, but in terms of long-term outcomes, survival, there's no real difference. So it's not necessary to reduce the spleen, but it may be helpful.
So our data set is different. So we did a retrospective analysis. Again, it's a retrospective analysis, not a prospective randomized trial, so you have to make certain limitations with that. But in the 175 patients that we recently published, the patients who had a splenectomy had a mortality that was half that in comparison to the patients who did not. And we adjusted for disease severity. And I think that's one of the issues in prior publications that have looked at splenectomy. They haven't really adjusted for disease severity. So you compared people who underwent splenectomy versus patients who didn't. The patients who got the splenectomy did worse. Well, they had worse diseases. So once we adjusted for disease severity, and once we also adjusted for comorbidities, we did find that their mortality was reduced if they had a splenectomy. So we also looked at spleen size, trying to figure out the question of how big the spleen would be, and I think that's a more difficult question to answer, so I'll just leave it there.
So would you, on that basis, then be recommending that even if someone had a huge spleen, or well, a moderately sized spleen, but they were not symptomatic and they were considering a transplant, would you recommend a JAK inhibitor for the purpose of shrinking their spleen before the transplant?
So I would.
Yeah.
I mean, obviously, there might be people who disagree. I would. And not only that, in patients who are refractory to JAK inhibitors, we've recommended that they have a splenectomy done. It is true that there is morbidity and mortality with that. I think it's very important that if you're going to do that, you send it to a very experienced person who has a lot of experience in doing it. And I will also admit that it is a point of controversy.
I was just going to say that.
People who
I
disagree with that. So.
Yeah, I tend to agree more with your point of view. That
Now, in terms of
it's
using
unclear
JAK
what the value
inhibitors
is.
before, do you see any detrimental effect on the transplant procedure itself, David?
I think there have been concerns raised about patients who go through withdrawal from the JAK inhibitor close to the transplant time, and you talked about using steroids. There was one report about using that as a strategy. But without that, there have been some reports of sort of a real cytokine storm and increase toxicity, hypotension, respiratory failure, renal compromise, perhaps because of this rebound. It's unclear, and I don't want to say that that's widely accepted, but that's a theoretical concern, and makes you wonder whether the right strategy is to withdraw, or should you just continue up until just at the conditioning?
Yeah,
But
we
that's
tend
really,
to do that actually. We tend to use the JAK inhibitor
Me too.
up until the conditioning. Then once
day
the
before,
conditioning,
actually.
yes, that's exactly what we do.
Exactly because of those
Yeah,
issues.
we had one case.
There are two
with-
papers we are all aware of from Germany. Small groups of 22 patients, 23 patients,
Right.
where
And,
the success was good. The French experience, unpublished as of yet, was like you described. So certainly a research question: when to use it, in who, for how long, until what time.
I did want to mention another danger of giving ruxolitinib is that's delaying transplant until they progress to AML.
Oh, yes.
And then in regards to the timing of when the ruxolitinib has been should be discontinued before the infusion of stem cells, obviously, there's a lot of debate about that. But as I said, we try to taper it off. So we do a taper, and we try to end that before the start of conditioning.
You brought a very important point again, Bart, about if a patient was already transforming and you have a lot of blasts in the bone marrow and peripheral blood. Let's say if it's like 18%, which is kind of very close to AML, do you cite to reduce, before you proceed with transplant?
Right. Boy, that's a really difficult one. If you had said greater than 20%, I would be able to easily answer the question and say yes.
Yeah.
So if they've declared themselves as having AML, then I think they should get cytoreductive therapy before they go into transplant. If they're in between this 10 to 20% range, that's a really difficult question, and it depends on a lot of different factors. It depends on the conditioning regimen you're planning. I certainly would not give that type of patient a reduced intensity regimen without giving them cytoreductive therapy first. If you're planning on giving a high-dose busulfan or a treosulfan-based regimen that has a high intensity, and you're concerned about the ability of the patient to be able to make it through the induction chemotherapy, then I think you could argue for these 10 to 20% people that perhaps you should go straight into a transplant. The thing we have to keep in mind is that you can give cytoreductive therapy, but what if it doesn't work?
Yes.
You're kind of where you were to begin with.
And the toxicity
and the problem, Yeah, and the problem is that in these patients in particular who have progressed to AML out of myelofibrosis, we know that they are probably the worst subcategory of AML patients. They don't have good responses to chemotherapy.
Right.
That's what we talked
we
about.
tend to use an azanucleoside in those patients. Decitabine is what we tend to use before taking them to a transplant. If they're like really close to AML or they have at the AML. I mean, as you know, it takes, a little while to, just because you need a transplant today doesn't mean you can get one today. So while you're getting everything else lined up, it's something to do.
Right, but that's one of the most challenging groups, those who have already progressed or are close to it, because we know the outcomes are much worse than patients who have not. And what's the benefit that you gain by trying to control the disease with induction versus the downside, the risks? We've had several patients in the last year with that scenario, and they don't respond well to standard induction therapies, so we've tried other kinds of clinical trials, but often there's complications, fungal pneumonia that comes along while they're going through their induction, and that certainly complicates what happens next. So I think the message is that you would like to get to the patient, get them to a transplant before they've
Right.
I
showed
think
signs
that's
of
absolutely critical.
Right.
The message is try to transplant them before they progress to, this almost AML type situation.
Yeah, and hence my analogy at the beginning, which was this whole, you have a young patient who has high-risk disease, who's doing well on a JAK inhibitor, That's
Right.
the patient that you really want to spend time educating and letting them know that a JAK inhibitor will not be curative. So,
Right.
yeah.
And just another thing, I think we would all agree, but let me know if it's not true, that we wouldn't preclude transplant as an option for these patients who have progressed to AML out of myelofibrosis,
Right.
because I still think that's their only curative
We
option.
agree.
So that was very lovely discussion on the role of a bone marrow transplant in patients with myelofibrosis. I thank you very much, and thank you very much for joining us today.